Welcome, everyone. We're just going to wait a little bit longer to see if we have a few more people trickle in here, but thank you for joining. All right, we'll go ahead and get started. Thank you, everyone, for joining our University of Colorado Firearm Injury Prevention Initiative webinar today on the public health approach, specifically focused on firearm-related suicide. I'm Erin Kelly, and I'm the Director of Research and Evaluation for the Firearm Injury Prevention Initiative, and I'll be moderating today. We have a great group of panelists to talk with you about the issue. Throughout the webinar, please feel free to use the Q&A. It's okay to even say where you're from and what perspective you're really wanting to hear more about. We really want you to interact and let us know what you'd like to hear more about throughout. We will also take a question and answer period at the end of the conversation today as well. So we're actually here today because the Colorado Office of Gun Violence Prevention held a roundtable on firearm-related violence prevention to take initial steps to build a comprehensive community-based approach to firearm violence prevention in Colorado. And we really hope to build off this momentum and continue a conversation about how the public health approach can be applied to preventing different outcomes that result from firearm-related injury, such as suicide, homicide, accidental shootings, and other issues. And this month, we really wanted to focus on suicide specifically. We will have a national and a Colorado focus as much as we can, just given that we're building off of the momentum from that previous conversation as well, but hoping that everything is applicable to the rest of the United States. We'll begin with an overview of what we mean by the public health approach, then dig into what some of the data say about the magnitude of the impact of firearm injuries and death have on and risk factors for those injuries and deaths in the United States. And then we'll have a panelist discussion that talks about implementation opportunities, collaborations, challenges, and opportunities for really learning more and evaluating those efforts as well. They'll provide clinical, community, and policy perspectives on the issue. So here today, and I'll let everyone, the panelists pop in and introduce themselves, but we are all faculty of the Firearm Injury Prevention Initiative. And Dr. Simonetti, if you want to start with your introduction.
Sure, thank you, Dr. Kelly. Please call me Joe. Thanks everyone for being here today. I'm Joe Simonetti. I am a clinician investigator at the Veterans Health Administration, and I am the Director of Mentorship and Education for the Firearm Injury Prevention Initiative. And I'm here today offering a perspective on firearm suicide prevention within clinical settings. Thank you.
Dr. Betz.
Hi, just great to be here. Thank you to everyone for joining us. I'm also happy to go by first names today since we're all friends. My name is Emmy Betz. I'm an emergency physician and researcher at the University of Colorado, where I'm a professor of emergency medicine, and I lead the Firearm Injury Prevention Initiative. And I'll be focusing today on my remarks mostly on community approaches to firearm suicide prevention.
Dr.
Hi, also happy to go by Chris. I'm Chris Knoepke. I am an assistant professor at the University of Colorado School of Medicine in the Division of Cardiology, but I am a social worker, both by virtue of my training and in my heart, and have been involved in firearm injury prevention for several years now, including with the Firearm Injury Prevention Initiative, where I'm now on the Leadership Council as the law enforcement lead. I'll be here today talking about extreme risk protection orders, otherwise known as red flag laws.
Thank you all. So I'll do a quick overview of just what we mean by the public health approach, just to have similar language. So to start, the assumption here of using a public health approach is simply that we're acknowledging that firearm-related injuries and deaths are a public health issue. And that's very much because public health addresses anything that affects the well-being of Americans. Firearm injuries and deaths do affect our well-being. More die due to firearms than car crashes every year at this point. Many more are injured than actually die as a result. And many more are even deeply impacted emotionally, whether they've lost a loved one or are living in fear of some sort of firearm-related violence. The public health approach was developed by the World Health Organization, and the Centers for Disease Control and Prevention uses it quite regularly. And it consists of 4 cyclical cycles, as you see, or 4 cyclical steps, as you see here. The first is really around surveillance and defining and monitoring what the scope of the problem is. The goal here is to really collect and distribute reliable data on the type of firearm injuries and deaths and the demographic and geographic information that is known about those deaths or injuries. The second step is to identify risk and protective factors. And the goal here is to not only know who, just as important as the surveillance step, but why these issues are taking place with different individuals or communities so that you can address the underlying risk factors that are present or identify protective factors that might mitigate against those risk factors. The third step is to develop and evaluate interventions. Really, the goal here is to make sure that the likelihood of success is increased so that you can actually have an impact in communities throughout the United States. And then step 4, the implementation step, is really to ensure the widespread adoption of those effective strategies. So really blending that scientific expertise we have with what works in a local community to ensure that we can really reach out and have the actual reduction in prevention of firearm-related injuries and deaths in our communities. I'll now transfer it over to Emmy to go through this first and second step on what the data say.
Great, thanks, Erin. So we start with surveillance. And again, this is a cycle. So after any kind of intervention or implementation, you want to be going back to the numbers to think about surveillance. So I want to start with big picture, not just suicide, but who is dying from firearms in the United States. These next few slides are using national CDC data from 2010 to 2020. And what you'll see for this setup along the bottom, along the x-axis, is age group in years. And then there are 2 y-axes. So the first one, which will be a line, shows the death rate per 100,000. And that helps us compare across populations. So you can see not just the number of people dying, but what it looks like per population. And then what you'll see in the solid color filled in is the total number of deaths, because that can let us see not just the rate, it can let us see the burden of a type of injury causing deaths. So when we first look at firearm death rates in the United States, this is what the picture looks like. And I think there's a few take homes. So first, death rates for firearms are higher in men than women across the board. And I want to acknowledge that these are crude categories of just male and female, which is how they're generally described in CDC data, recognizing that there are more nuances, but still, much higher death rates among men than women at all ages. But there are these 2 peaks in men in the kind of late teens, early adulthood, and then in the later years. When you look at the solid number, so the solid color, the number of deaths, you can see that the peak there is in the younger age groups, particularly among men. And that's because there are fewer older people. So although the death rate among men is very high from firearms in the 70+ range, that's predominantly from suicide, there are fewer people dying. So that's where you see the burden is different. So overall, we know that about 86% of firearm deaths in the United States are among men. So next, also looking again at somewhat crude categories, but by race and ethnicity, same setup as the prior slide. But what you can see here is that we have some different patterns for different racial or ethnic groups. So there's this very high spike in non-Hispanic Black. This is looking just at men, non-Hispanic Black men in the late teens to early adulthood, predominantly from suicide. And then if you can see the purple line, it kind of gradually goes up over time. That's non-Hispanic white men. And you can see that the rate is higher in the later years. That's predominantly from suicide. If I superimpose women here as well, you can see that for all races and ethnicities, really rates and number of deaths are lower for women than men, as we talked about on the prior slide. But we see sort of the same pattern that for non-Hispanic white individuals, there's a later peak in the later decades, predominantly from suicide, whereas for individuals of color, there's a higher peak in the younger years, predominantly homicide. Given the makeup of the US population, overall about 62% of firearm deaths occur among non-Hispanic white individuals. But it's incredibly important to recognize that there's at least a 5 times higher firearm death rate among individuals of color, particularly non-Hispanic Black men. That's predominantly from homicide, an incredibly important problem that we're not going to be focusing on today. But this is really the first step in surveillance, is understanding the full picture and then diving down into a particular area, or in our case today, a particular cause of deaths. So next, looking at the reason for deaths, and I've already alluded to this, we know that there are varying patterns and varying causes of firearm deaths. In the United States overall, about 60% of firearm deaths are due to suicide, and then about 36% from homicide. The other causes, so accidental or unintentional shootings, mass shootings, are a tiny fraction of the total deaths, although I don't want to underestimate the psychological impact from those deaths. And legal intervention or police-involved shootings, also a small number, although I want to recognize that there may be undercounting of those deaths. It's important to recognize that in Colorado, our burden of suicide is higher. So specifically, more of our firearm deaths are due to suicide. In 2020, 72% of all firearm deaths in Colorado were due to suicide, which is one of the reasons that we here at the Firearm Injury Prevention Initiative at the University of Colorado Andrews Medical Campus focus so much on suicide, because that is such a big burden in Colorado. Now, we can also flip the statistics a bit. So if we look at total suicides in Colorado, what proportion of suicides are due to firearm? And what you can see is that pretty consistently over time in Colorado, which is true in the rest of the United States as well, about half of all suicides are due to firearm. So for Colorado, again, if we want to reduce firearm deaths, we need to be thinking about suicide. And if we want to reduce suicide, we need to be thinking about firearms. So this next slide is a screenshot from the existing suicide data dashboard available for free to anyone at the Colorado Department of Public Health website. The QR code there will take you right to it. And I want to make sure that especially our Colorado audience listeners are aware of this incredible resource, because what you can do basically is scale into particular years, particular counties, particular methods of suicide. You can see that there's a map of the state showing the number of firearm suicide. This is why the screenshot I took was for firearm suicide. But you can see the number of firearm suicides in counties from 2004 to 2022 in this case. You can also on the right hand see then the demographics, and a few things again jump out. Higher suicide numbers in the middle age and older adults, mostly men. You can see high, you can also see that there are numbers then by marital status, veteran status, and so forth. From this website, you can also look at rates, again, which allows you to compare across groups to identify risk factors. So this is another screenshot. Again, the QR code will take you to the website where you can put in different things. So this is now looking at the known circumstances surrounding some of these firearm deaths. A few things just to highlight. So on the left-hand column, you can see 42% of people had a crisis within the 2 weeks prior to death. It's well known that many suicides occur within the context of a crisis, often related to jobs, housing, relationship status, and so forth. And then you can see that about 40% of individuals had a current depressed mood, according to friends, family, law enforcement, which also goes with the contribution of mental illness to suicide. So I encourage you, if you live in Colorado, to go to this dashboard, start digging around so you can understand what it looks like in your county or in your geographic area or for the particular population that you're working for. So this takes us really directly, we've already kind of slid into the next step of the public health approach, which is identifying risk and protective factors. We can start to see patterns in terms of who appears to be at higher risk of dying or not dying from a particular cause. And we're focusing today on firearms, and I want to really explain why we know that firearm access is a risk factor for suicide. So we know from extensive research that only about 10% of people with suicidal thoughts or actions die by suicide. So it is not a terminal disease or an inevitable outcome. We know that people get better. But we know that when someone uses a gun in that moment of crisis, it's most likely that they will die and actually not even reach a hospital. So 85 to 90% of suicide attempts using a gun end up with the death of the person. And we know there's often a pretty short period of deliberation in the space of minutes to hours for someone who is at risk of suicide, which is why we know it's so critical to keep people safe during those times of risk. And overall, it's these factors that then contribute to what we see well established in the literature, which is that there's at least a threefold risk of suicide death when there's a firearm in the home. I want to say that again. So firearms in the home increase the risk of suicide death by about threefold. And that's not because the gun makes someone think about suicide. It's just because it makes it more likely that if they act in the moment of crisis, that they are likely to die because there's no second chance when someone uses a gun. And so the overall message that we are looking at in firearm suicide prevention is really about reducing firearm access for those at risk. And I have the photo here because we often talk about it like a designated driver, like a friends don't let friends drive drunk approach. It's recognizing that this is hopefully a temporary impairment and that we want to keep our loved ones safe while they're getting through a period where they're not at their best. I also want to acknowledge that reducing access to lethal means is just one part of a much bigger puzzle when we think about preventing suicide. Absolutely, and we're not going to talk about this as much today, but absolutely we need to have effective and available mental health care. We need to increase help seeking. We need people to be aware of crisis lines, to be reaching out for help. We need to reduce stigma about asking for help and so forth. But today we really want to be focusing in on reducing access to means because we know that it works. And so now I think I'm just gonna show this one last slide that we're gonna transition over to the panel. Yeah, come on back on, Erin. As we start to think about then, now that we know from surveillance and identifying risk and protective factors, what kinds of things might actually work in terms of interventions. And I will turn it back over to Erin.
Perfect. Thank you so much, Emmy. That was great. So we will start by just kind of discussing really, given what we know now, that we've now looked at those first two steps, right, of what the data say in terms of who are at risk and what risk factors might be present, and we'll focus in on that reducing access to means specifically, given the firearm focus here. We want to hear from Joe, Emmy, and Chris around those clinical, community, and policy perspectives related to opportunities that we have to address the issue. Joe, I'll hand it to you to kind of start from a clinical perspective.
Sure. Thank you, Erin. Thanks, Emmy. So I want to start off by saying I'm not sure it's like intuitive to a lot of people when we talk about public health approach to firearm suicide prevention that many people initially begin thinking about clinicians or the clinical workforce as the individuals to sort of participate in this work. And I'm here to make this sort of case that I think that we absolutely should be, as we are in many healthcare systems today. And there's a good reason for that. If you look at the US Census data, the healthcare workforce is the largest workforce in the country. It's about 20 million Americans work in the healthcare sector. Of those, about 1 million work in mental health care, whether those are psychiatrists, psychologists, social workers, et cetera. And if you just look at the Colorado Hospital Association data, there's more than 100,000 individuals in Colorado who work within our healthcare systems here. And so we already have a tremendous group of individuals who are employed nationally and within Colorado, whose job, day-to-day job, is to show up and take care of the health of individuals. And so to not consider them, I think, an important tool when it comes to addressing firearm suicide prevention through a multifaceted approach, I would think we have to make a pretty strong argument that they shouldn't be involved in that, considering it's really what they come to work to do. One of the chief interventions that I think we're already delivering in a lot of different settings in healthcare is referred to as lethal means safety counseling or lethal means counseling. Maybe more generically, you could call it firearm safety counseling. And this can take, I think, a lot of different forms. But generally speaking, it is a clinician who has identified a patient who may be at risk for firearm suicide because of some risk factor that they've already identified. So maybe that's depression, maybe that's the diagnosis of a terminal cancer, or maybe this is someone who is engaging in a well child visit with a teenager, and in the absence of identified suicide risk factors, they decide to deliver counseling on firearm suicide prevention because they do it for all their patients. Lethal means counseling is something that clinicians routinely deliver. Part of it can be assessing access to firearms and how firearms are stored within households, potentially assessing other behaviors related to that could put individuals at risk for firearm suicide prevention, and then making recommendations on ways in which you can reduce firearm suicide risk, including through secure storage practices within the home, finding secure ways to store firearms outside of the home, and not just making those recommendations, but working with the patient who, when you're at the bedside or when you're in a clinical office, to figure out actually what works for them. So of the dozens of solutions that I can come up with as a clinician that I know would reduce, say, the firearm suicide risk for your adolescent, what are the ones that we think are achievable within your household? And are there things that we can do to make some of these things a little bit more achievable? You know, it's, again, it's a thing that's happening pretty frequently, I think, in routine care, certainly within mental health settings. When we get into sort of some of the implementation challenges, we can talk more and more about maybe the future of lethal means counseling and some things that we have to address to sort of increase the uptake of it. Aside from lethal means counseling, which is sort of this sort of generic phrase for what we do as clinicians when we engage with our patient populations about this, there are a lot of specific interventions that have been developed for firearm suicide prevention that don't necessarily have to be housed within clinical settings, but we're finding more and more are acceptable to be delivered within clinical settings. So we have, you know, in our group developed, for instance, the Firearm Life Plan. So for individuals who are thinking about physical or cognitive or mental health changes that often accompany life during older years, what are some things you can do within the house with respect to your firearms to make sure that an individual and their family members and other people visiting are safe? The VA has developed, and specifically in Colorado, the VA has worked with healthcare systems in Colorado to think about what specific clinical interventions we could develop for clinicians for our veteran populations as well as their family members. So there is a lot of opportunity, I think, for our clinical workforce to engage in firearm suicide prevention, to be one of the tools that we bring to bear for what is a pretty significant public health problem, as I think Emmy outlined. Obviously, at the Firearm Injury Prevention Initiative, one of our arms, one of our things that we do is firearm suicide prevention education. And so we're fully available to not just clinicians, but also the community. And so if individuals are interested in learning more about how to facilitate some of this work within clinical settings, we're fully available for consultation. So please reach out to us, because it's really what we love to do. It's what we show up to work to do. Also, I just want to point out the Bullet Points Project. If you just search for that in the internet, and we'll throw it in the chat real quick. It is a really fantastic a website that's been developed by the folks at University of California. And it has great resources in terms of providing not just sort of the background information for why access to firearms matters in terms of reducing suicide risk. A lot of that Emmy just kind of went over, but also gives like really good examples and tools for how clinicians can get involved and deliver some of this counseling, including some vignettes. So I think it's a really fantastic resource that you should take a look at if you're interested in this. Thank you.
Emmy, take it away if you want to offer some community perspectives.
Yeah, thank you. So I agree with everything Joe said. And I'm a clinician, I work in the ER and lethal means safety counseling is also, I think, standard care for us and in certain circumstances, particularly with suicide risk. I think it varies from setting to setting in terms of who does it, but so wholeheartedly agree with Joe's comments about why clinicians should be doing this. But I think I've also recognized over time that unfortunately a lot of people don't make it to me or to their primary care or to their outpatient setting, that there's still so much stigma around help-seeking behaviors, which we're continuing to try to fight against. But that's why we really need to be also out in communities where people are at and recognizing that some people are not going to seek care from their clinicians. And that's where I think we really need to think broadly. Where are the communities that where are the sort of trusted messengers? We know that in the firearm space, it's a highly sensitive topic, highly politicized. We're really proud at the initiative that we're taking a nonpartisan, neutral approach, and we're excited to engage with people from all backgrounds to find solutions that work for them. But so I think we need to think very seriously about, what are the really trusted communities, and that's why we here in Colorado have been doing a lot of work with the firearms community, and I've been really excited to see what's happening at a national level too. So just a few examples of that, and we'll put some of these links in the chat as well. So there's the so-called gun shop project that many people hopefully are familiar with, which started in New Hampshire and now has spread to a number of states, including Colorado. That's run through the Colorado Department of Public Health and Environment, but it's really an upstream approach to raise awareness around suicide and the role of firearms and why safe storage or secure storage can save lives. And the idea is posters, brochures, conversations at gun shops, at ranges, at a place where people maybe already feel safe talking about their firearms. How can we get that messaging out? There have been additions to that, I think, in terms of things like firearm instructors talking about suicide prevention through their coursework. Some other groups, Walk the Talk America is a really, really interesting organization that's trying to bridge the gap between outpatient mental health and the firearms community and sort of making both sides more aware of the other side, if that makes sense. And they have some web resources. And then I think it's also, thinking beyond just like firearm owners as a group, but even within that, thinking about different even subgroups or subpopulations who might be more or less interested in different kinds of topics. I'll just mention a couple of the other things that I think seem really promising. We're excited to be doing work at gun shows with the general public, tables and booths and things, and providing locking devices with a kind of standardized interface, I would say, or a brief conversation that's based on one developed at the University of Washington. We've had really wonderful responses, I think, so far to that, and have been thrilled to see that take off, and are looking forward to doing more of that. I think there's also lots of opportunities for work with military communities. We were excited last summer at the initiative. We co-hosted the first ever national summit on firearm suicide prevention in the military with many military leaders to talk about some of the unique challenges within that group. And then the last thing I'll mention, we could go on and thinking about different communities, but I also want to call out the role of faith communities as recognizing that they are a community where there can be a really incredible sense of trust and being able to open up about problems. And so thinking through, how do we engage faith leaders, for example, in having the resources, the language, the skills to be able to talk about firearm access in particular when someone might be at risk of suicide. So I think lots of promising things. I think one of the challenges, we don't know totally what works yet. And that's one of the things we're trying to help dig into to understand what best practices are. But it's been, I think, just really exciting to see over the past few years how many things are taking off.
Great. Thank you so much, Emmy. Chris, if you want to talk about ERPOs.
Certainly. So I'm a clinician in a little bit of a different way. I haven't seen people in a few years, but as a clinical social worker, I think not just about the person who I'm talking to and the person who's in front of me, but also how systems might work together to effectuate the kinds of safety and other outcomes that we want, such as preventing suicide. And one of those tools, and one of the sort of more aggressive civil legal tools that are out there, are these extreme risk protection orders or red flag laws. They get a lot of attention in the media and otherwise for a variety of reasons. But what I want to say is that they are not a common tool. They're not the first thing that we should be doing. And it's one of these things that I think we're just sort of folding into the entire sort of toolbox or repertoire of things that might be available to clinicians or law enforcement or family members when they know of somebody who's in crisis, whether that has to do with threats being made toward themselves, so suicide threats, or if they're threatening other people, or pretty commonly both. This is also a point where I want to reemphasize that we're not engaging in any sort of policy advocacy. We're following the science and sort of trying to illustrate the opportunities where these kinds of orders might be effective in helping to prevent deaths. So the things that I like to highlight are that while these are available sort of pretty generally, and we're growing the number of folks who can petition across the state. In Colorado, there are only a few sets of people who can petition for these. And so we think of these as tools sort of for specific groups of individuals. First and foremost is law enforcement. So the vast majority of petitions for these are coming from law enforcement. That's true in Colorado. That's true everywhere else. We also know, particularly in Colorado, that petitions that come from law enforcement, whether they're for suicide or for anything else, are more likely to be granted than ones that originate from family members or potentially from other professional groups. But the second group of people who can petition for them are family members, and family members sort of is a little bit squishy, but really sort of generally it means someone who's either related to the person who they're filing against, who shares a child with them, or who has lived with them in the last 6 months. So this is meant to sort of both put eyes on people from very close by, and also to protect those in the sort of most immediate vicinity of the person who might be at risk. And then the third, and this is a very new phenomenon, at least in Colorado, and we're not exactly sure what's going to happen or how many of these petitions are going to be or how they'll be used. But clinical health providers, so those would be healthcare professionals and mental health providers, such as all the groups Joe talked about earlier, as well as educators, can now petition against people who they have a professional relationship with within those circumstances. There's a number of things that I think that we would want to sort of understand about these. When you see them talked about on the news, most commonly they're talked about in terms of preventing mass violence. And the law that created the ERPO system in Colorado is named after a deputy from Douglas County who was killed in an ambush on New Year's Eve 2017 while responding to threats being made online by somebody who they knew. But more commonly, and where the evidence sort of points us, at least at this point, is that they can be a reasonably effective tool at preventing suicides. And we're gathering data here in Colorado, but earlier data out of Indiana seems to indicate that for every 10 to 20 ERPOs that are granted, you prevent at least one suicide, which is kind of remarkable given the diverse circumstances under which they're petitioned. I think that I might want to stop there and allow more opportunity for Q&A. But I think that I want to reemphasize this is a tool at the very end of the spectrum of the kinds of things that Joe and Emmy were talking about before, where both clinicians and other people can be involved in trying to engage with people who are at risk, who are at that very top of that pyramid within the public health model.
Thank you so much, Chris. And again, just kind of bringing this together here. So I think we're really talking about these community perspectives where we can talk about the importance of having secure firearm storage more upstream. If you have a firearm in your home or near you in some way or shape or form, how do we keep these safe for everyone involved? And then how do we move to this as people become at risk or individuals around you do? Are there options for making sure that those are not in your hands during a time of risk to yourself or to others, right? So let's shift, I think, because you all started to talk about this a little bit, into challenges in these efforts, whether it's learning more about them or making sure we have a trusted messenger. I'm curious as to what you all think about next steps for the work that you've been doing. Joe, do you want to start?
Yeah, I'm happy to. I mean, there's a lot of challenges. I said earlier, I think very confidently, like, hey, we've got 20 million healthcare workers in the country. Doesn't that sound fantastic? And more than well over 100,000 in Colorado alone. But I also didn't mention that most of them have not been trained to engage in conversations about firearms. And most of them don't work in mental health or suicide prevention, even more broadly than that. And when you look at the folks who are dealing with mental health issues or other issues that put you at risk for suicide or who go on to die by suicide, many, if not most of them, have actually not seen mental health clinicians. On top of that, a lot of our systems are getting smarter because of that and are expanding our suicide risk screening and evaluation protocols sort of into other spectrums. And so you could be in primary care and get screened for suicide risk. You might be hospitalized on a general surgery floor and be asked about your suicide risk now. That's not to say that we've trained all these clinicians to engage in firearm suicide prevention, nor do all these clinicians, I think, rightly understand or believe that it's really their responsibility to do that. People are busy. When you look at the national data, about 7.5% of Americans who have access to firearms have said, yes, a clinician has previously talked to me about guns. And when you look in the Veterans Health Administration, a system that I think really has sort of led the way in terms of prioritizing firearm suicide prevention, is about 14% of veterans say that a clinician has at some point in their life talked to them about suicide risk related to firearms and firearm safety. So that's okay, but quite frankly, it means we've sort of got a long way to go. The biggest question I think we have in terms of implementation is how do we actually make that happen? If you look at some of the studies, and every few years somebody publishes a new study, usually focusing on primary care, and it says, if they were to do everything they're supposed to do, that is, check all the boxes in terms of depression screening and make sure that the medications are refilled, and also respond to what your patients they're visiting you for. What are their concerns? The clinician's average day would be between 20 and 30 hours, right? So folks are busy. People working emergency department shifts are very busy. And so how do you prioritize firearm suicide prevention within all the other things that patients want and we know that we should be doing? And then obviously there's a lot of heterogeneity across these clinical settings, right? Even a primary care practice in the VA is going to be very different from a primary care practice at CU Anschutz, which is, a quarter of a mile from here. What are the different needs of clinicians in those clinical settings if you're going to enable them to actually deliver lethal means counseling? And then maybe we can get into this later, but like a whole other thing is, how do you make this work for patients, right? So one thing I can train everybody on this call to have a conversation about firearms. I mean, that's what I do day to day. That doesn't mean that's exactly what every patient needs. And so how is it that we come up with different interventions that are flexible, that are effective, but are also patient-centered in a way that they meet the needs of the individuals who are coming to see us?
Thanks, Joe. Emmy, if you want to talk.
Yeah. So I think what I'll say first, one broad concern from any community I think that we hear is like, wait a second, I'm not a psychiatrist. How am I supposed to know? What am I supposed to be doing? And I think thankfully that one sometimes can be overcome with an explanation of what it is you're really asking people to do. And that's to learn how to recognize somebody maybe is going through a rough patch, to not be afraid to ask that question, and then to know how to get people to help. So specifically the 988 crisis line, which is always available, and to help communities realize like they don't have to fix the whole problem and that they're not alone in this. So I think we often hear that, like, I don't want to get involved because I don't know how to do this. And thankfully, sometimes what you're asking in community settings can be a lower bar, I think, in terms of just getting people to start having the conversations. I think more specifically in one community, in the firearm retail and range community, I think a couple of things, and I say these also for anyone out there who's thinking of trying to do this work. So the first thing is, I think you have to make this voluntary. So trying to go into any community and say you have to do this is a terrible idea, in my opinion. So, you know, for example, legislation requiring retailers to do this, I think would be a huge mistake. I don't think it's being proposed, but I just want to make that clear that this really needs to be about engaging communities in things they're excited about and things they want to own and they want to run with, and not requiring them. Because I think particularly with firearms, anything that is required really can rub people the wrong way. I think, though, one of the other things, you know, we hear specifically from ranges and retailers around storage. So we do a lot of work encouraging out-of-home storage for people who might be in a time of risk, because we know that's the biggest risk. That's the best way to reduce risk in terms of putting the most time and space between a person and a gun. So then the question is, like, how do you actually do that? And there are state to state some concerns around things like liability and storage practices and so forth. And so I don't say that to scare anyone away from this, but at the same time, just to acknowledge, you know, that whatever community you're working with, there are going to be specific questions, concerns. And I think the most important thing for us as public health practitioners is to go in listening and to try to understand the views and the needs of that community, and then figure out how you can overcome those specific challenges, rather than thinking you're going in with all the solutions.
All right, go ahead, and Kristen, it looks like you wanted to answer a question too.
Oh, I had a question that came across there too, and I'm happy to answer it whenever it's appropriate. But I think that speaking generally, especially when you're looking at ERPOs or other sort of legal tools that are used to effectuate firearm injury prevention, it's a challenge there is fighting the sense that ERPOs are the beginning and end of all firearm injury prevention efforts, and recognizing that they are a strong tool, they are potentially a very effective tool, but that they are also conscribed to a couple of pretty specific kinds of circumstances, and when other things frankly haven't worked. Other things such as voluntary storage, minimizing risk through other access restrictions that don't necessarily get the civil legal system involved, are of course preferred in sort of a least restrictive environment sort of way of approaching people with dignity and autonomy, right? And so I believe very strongly that is something that we need to figure out how to message better, both from a public policy perspective and then from the perspective of those of us who are just interested in doing the best for our communities.
Perfect. And I think so I want to reference back to the public health approach, because an important piece of this is identifying what's effective that can really create the changes in communities. And I think we've all addressed the fact that we're still studying some of these things that you're talking about to make sure that we're doing it the right way for different groups of people, different communities, right? And I wonder if you can give a sense of how you're measuring it to make sure that it works at this point in time, and even examples of collaborations at play potentially around research and community partnerships that we might all have with the Firearm Injury Prevention Initiative too, to give a sense of who those collaborations are and how we're really trying to understand the impact so that it can be spread more effectively. Joe, if you want to start.
Yeah, it's a great question. Measurement is really critical, not only to figure out if what you're doing is working, but why it's working. A lot of the things that we do in clinical practice are often implemented without study. And I think that it is really critical when we're thinking about something as important, and I think also as sensitive as firearm injury prevention or lethal means counseling more specifically, that we are doing our earnest job to actually studying it, to know that it works and make sure that it's actually effective. There's a lot that needs to be measured. And I think, first of all, it's just sort of the feasibility of doing it, sort of trailing on my prior comments about what are some of the challenges that actually getting this into clinical practice. I think what we probably need more in the research world is folks to adopt a dissemination implementation lens that is really looking at obstacles to delivery and adoption across clinical settings and how things have to be adapted so that they can be delivered feasibly. What we always want to do is look at outcomes. It's a typical challenge, I think, in suicide prevention, which is to do interventions in which you can actually go on to measure reductions in suicide, which is obviously what we always care about. Just for lots of reasons, that's actually a very difficult thing to do. And so what we tend to measure before that is changes in behaviors, changes in the way in which individuals use or store their firearms. And that has been so far, I think, accepted as a reasonable proxy outcome for a lot of the clinical interventions that we do. Although I think, as scientists, I think we have to at some point, and I think very soon, go beyond that to actually put more evidence behind it in terms of actual suicide outcomes. One of the things that I think there's actually been a reasonably good literature base on so far, and a lot of us have sort of contributed to it, is about how patients actually feel about these conversations. We're in this sort of process of developing interventions and teaching clinicians on how to have these conversations. We have to know how folks want to have this information delivered and what things we have to keep in mind to deliver it so that it's acceptable. And so far, I think we found really, really important stuff. The qualitative studies where we go and we interview patients about how they think about this, they've given us really good insights into what matters. And that's having a trusting relationship with a clinician, having a patient-centered one-on-one conversation with individuals, being mindful that firearms are valuable to individuals, and that some folks are going to come to the table a little bit guarded about not just potentially feeling judged during conversations, but also I think the implications of disclosing firearm-related information to a clinician and to a healthcare system, or certainly within the VA to a federal healthcare system. I think those studies have given us great insight into how we can do better about our counseling. But the most reassuring stuff that I've seen is the work from the National Firearm Survey and a couple others, which have shown that a vast majority of individuals and a vast majority of American gun owners say that at least sometimes we should be having these conversations. And specifically when somebody's at risk of suicide, it's about 90% of Americans and American gun owners say that yes, clinicians should at least sometimes be talking about firearms and firearm safety as part of routine care. So some of the measurement we've done, I think there's a lot more that we need to do in terms of acceptability and efficacy, but we know what those measures are, and they're already being employed in the studies that we're doing.
Great,
Yeah.
Go ahead.
Yeah, thanks. So I think in the community space, some of it's very similar. It's around things like attitudes and of whatever organizations, gun shops and so forth, to be involved, asking them about the challenges through either surveys or through qualitative work. When it gets to trying to understand the effect of those programs, some of it is, I think, we think about that you have to change someone's beliefs perhaps before you change their behaviors. And so looking at things like attitudes in the public or in customers around a belief between the link between firearm access and suicide risk. So can you change someone's view to make them realize, like, oh, this should be locked up when someone's in crisis because it's related to their risk of death and so forth. So we often use measures like that. It's great if you can call people for follow-up a month later and say, hey, are you doing anything different? But that's really hard because then it's not anonymous. I just want to make the point for those who are thinking about what to do in their own communities, counties, and so forth, to please not start from scratch. There are, as Joe was saying, we know a lot about things like trusted messengers and the need to do this in a nuanced, appropriate way. There are lots of resources already out there, including we have a handout we've developed around home firearm storage that we think is nonpartisan, non-judgmental, and so forth. We're happy to share that. We're happy to point people to other existing resources, but I really just implore people to not start from scratch because it's a waste of effort, but also not start from scratch and be thoughtful about what they're using so that they don't unintentionally alienate the group that they're working with. This is just such a sensitive space. I will say too, there are existing surveys acceptability questions, those kinds of things out there. So you don't need to start from scratch with that either. If you're thinking of doing a pilot program or you want to assess attitudes and so forth, we're happy to share ideas with people or share the kinds of, like the survey we use when we're at gun shows, giving out devices and so forth. So that kind of gets into the implementation piece too. It's around understanding at least even pieces of what's acceptable, what seems feasible to do, what kinds of handouts, what kind of questions to be asking, and how do you then scale that up? So I do think it's really important, and it may be hard, but it's critical that we do try to collect data on programs to see what's working and to see what's not working.
Sorry, go for it, Chris.
Well, I can circle back to this this question that that Alana Smart put in the Q&A. For those who didn't see it, she said, the biggest question our clergy had about when to suggest ERPOs was risk assessment, and how do I know that the risk is great enough to encourage this step? So this is sort of a central question for anybody who's faced with anyone who might be in crisis. And so I apologize for answering within a public health discussion with some very micro direct practice kinds of things. But I think that when I think about this in terms of direct practice, first of all, again, this isn't the only tool that's available within the tool chest, right? But if you think about risk assessment itself, there's a great book by a guy named Gavin de Becker who wrote The Gift of Fear. There's lots of fun anecdotes we could have about him, but he owns a business that does threat assessment and security protocols for like famous and wealthy people in the Supreme Court and all these folks. And one of his quotes about risk assessment is that threats betray the speaker by proving that he's failed to influence events in any other way. Most often they represent desperation, not intention. So from a direct practice standpoint, what that says to me is that when somebody is making threats, you might want to attend to the desperation, you might want to attend to the hopelessness, you might want to attend to the disconnection, right? Like, and all of these are very central to risk of suicide. And yet at the same time, you as a professional, I need to listen to your intuition, because in the very same book, he said intuition is always right in at least two important ways, in that it's a response to something and it always has your best interest at heart. So when you have that sense, that intuition based on your personal experience, who you are, what you've done before, that's the time to reach out and get consultation, either from other clergy, other professionals, others who you trust, as a sounding board at the very least, so that you can figure out a plan to move forward, not just with ERPOs, but with anything else that you might do to help that person in their particular circumstance.
Great, thank you all so much. We do have a few minutes left if there are any questions from the audience members at this point in time. The answer is yes to the one that just came in. We have been recording the conversation. So we will post that on our website and send it out in the next newsletter afterwards. Are there other questions from the audience about what you've heard today, or what you ask questions around what you think you should do next? We're very open to engaging in conversation. Again, we want to reiterate that we are here for you. I think if you're at the point where you know you want to be doing something but don't know where to start, Emmy mentioned this, but there are resources available to you, and I think our job is to really help you navigate what those are and what the specific needs of your community are. So I'm always happy to do individual chats after.
Erin, can I ask a question while we're waiting to see if the audience has more? I think a question I get from a lot of people who are fed up with gun violence, sick and want to do something. I would love to hear the thoughts from each of you, actually, including you, Erin. Like, what would you say to those people? Imagine it's someone who's not in a position of a public health agency, but just someone who wants to get involved. It's a big question, but I get asked it all the time. So I'm asking you now. Okay, Erin, you go first. Oh, Joe unmuted. So
yeah, there's lots. We have these, I think we're all in this work because at some point we felt like that, right? And we didn't know what to do, and we just kind of did something, and here we are today as a group of colleagues and friends trying to do this. I think the most fundamental thing is that you have to learn basic information. There is so much conversation about firearm injury prevention. There's so much conflict about it. There are mixed messages about it. And I think that understanding some of the basics about, for instance, within this conversation, suicide prevention and what really matters and why the role of the firearm is something that's worth talking about, I think is really critical. And maybe you don't see how that ties into sort of preventing the next media event or the next school shooting that all sort of keeps us up at night. But if you just look at the sheer number of people who are at risk of suicide or have mental health or addiction issues in our own communities and our own families, there is something that you can be doing. One of the things that, for instance, I hear every time I give a talk or every time I'm working with a community or a family member or a patient or another clinician is, well, I talk about the firearms. If somebody just wants to die by suicide, they're going to find a way and they're going to die. That's a myth and it's incorrect. And maybe at some point we all kind of felt that before we learned something different. There's some basic things that you can learn that will give you better tools to sort of address this on a day-to-day, whether that's comes up in your family, whether that comes up in your school, whether that comes up in any of the work that you do. I think that you have to go out and learn the basic stuff about this so that you can bring it with you elsewhere.
Thanks, Joe. How about Erin?
Yeah, what Joe said, absolutely. The other part I think I would have too is just like a willingness to learn and embrace all sorts of perspectives is, I think, an additional piece of that of to enter into a space that you might not be comfortable with is, I think, a really hard to do. It's increasingly difficult sometimes in society today. And this is one of those topics where you will. And I think really just being open to hearing people's perspective and finding the commonality and the shared experience among people is something that I've always found exciting and really promising. And that exists in this work and is something that I think continues to motivate me personally. And really makes our research and practice more effective of finding that shared language and common space.
Chris, anything to add?
I can't follow up on either of those or add very much to it. I do think that this is a tough area to be in, but it's a tough part of our world that we're dealing with, and it's going to require both knowing the basics and what's actually true, which is increasingly hard in an environment where there are deeply entrenched viewpoints that don't often like to agree with each other, but that there are these little islands of agreement on which we can try to do our best work.
We do have one specific question from the audience. That was a great question, Emmy. Thank you. We mentioned tables, and I think for outreach events. Emmy, do we have those at Tanner gun shows? Was the specific question?
Yeah, not at every Tanner gun show. We've been to some, along with like the International Sportsman's Expo. So through the initiative, we have a full-time coordinator, Matt Wettenkamp, who's wonderful. He's a veteran and firearm owner himself. And so I think that speaks to sort of the credible messenger piece. He can speak really well with customers and so forth around firearm injury prevention and suicide prevention. And, I will say when we went to the Tanner show the first time, it was a couple things struck me. So first, we were the only place selling or giving away storage devices, which I think then to me suggests a huge opportunity. Second is that I think a lot of people were wary of us because they saw the CU logo, but then as soon as they talked to us, I think it became clear we weren't there to like lecture anyone, that we were truly just there to promote secure storage and reduce injuries and deaths. And then people, I think, were very open to that. But so I think it does speak to the need to be thoughtful in how you approach opportunities like that. And then we had really great conversations with people interested in locking devices and share, a lot of people sharing stories, a lot of particularly veterans who came and shared stories of losing friends to suicide and so forth. So we're going to be hopefully doing more. We're looking for opportunities to do that kind of outreach. Matt recently was at a rodeo also up in Eagle County. So if you have ideas, if you want us to come show up, please let us know. And if you are interested in doing something like that, Also, please reach out. We are happy to share our tips and tricks on how to have what we think are effective and respectful conversations around firearm storage, and also happy to share tips on what kind of locking devices to give out.
Great, thank you. We are close to time, so thank you everyone for being involved today. Again, reach out to us. If you have any questions, interested in partnership, learning more, we are happy to be of support to everyone. Have a wonderful rest of your day, and we will send a note for the next one that we'll do in coming months, also using public health approach to addressing different firearm injury and death related topics. Thank you so much.